Hello, I'm Greg Albers, Professor of Neurology and Neurological Sciences at Stanford University in California. Welcome to this latest program in our series of challenging cases in AF and VTE. We'll be discussing key diagnostic and management criteria in the setting of emergent care of suspected acute stroke. I'm very pleased to have joining me today Dr. Chris Diener from the Department of Neurology and the Stroke Center at the University of Duisburg-Essen in Essen, Germany. Welcome, Chris.
Hi, Greg.
Great to have you here. I want to present a case and get your thoughts about management. The patient's a 70-year-old lawyer. He suffers from hypertension, diabetes, high cholesterol, and atrial fibrillation. He's a smoker who quit 5 years ago. He's admitted to the stroke unit with acute weakness of the right side and aphasia. The symptoms started about an hour ago. His initial CT shows mild small vessel disease, no evidence of cerebral hemorrhage, but his wife indicates that he takes an oral anticoagulant. So first question, would you treat this patient with intravenous thrombolysis?
Yes, for a very simple reason. He obviously had an ischemic stroke. Cerebral hemorrhage is excluded. He's in the time window to perform thrombolysis, and a little bit of small vessel disease would not constitute contraindication for TPA. The issue is his anticoagulation.
Right. So we've been told that he's on an anticoagulant. We don't quite know which one it is. How are you going to decide what he's taking and whether it's safe to give him TPA?
Well, there are two options. He could be on warfarin, and in this case we would need to do the INR to see whether he is anticoagulated or not, or he could be on one of the non-vitamin K oral antagonists. So it's either the bigatran, a thrombin inhibitor, or it's one of the 10A inhibitors. And for the bigatran, we could use the APTT. If the APTT is prolonged, he definitely took the bigatran, and in this case it would be a contraindication. If the APTT is normal, this shows that the last intake must have been more than 48 hours ago, and we could continue. The problem with the 10A inhibitors is that we would need to do an anti-10A activity, which usually takes an hour. So he's still within the time window of thrombolysis if we wait for the results of the anti-10A activity.
Okay. Well, let's assume that it's actually warfarin that he was taking, and you've already indicated you'd order an INR test. How would you interpret the results? What INR level would you use to decide it's too much to give thrombolytic therapy?
Yeah, we have data from the Get With the Guidelines registry from the United States. And the data from this registry indicates that if the INR is below 1.7, it's safe to do thrombolysis. There is no increased risk of intracerebral bleed. But if the INR is more than 1.7, TPA is contraindicated.
Okay, so that's pretty straightforward. So for dabigatran, then you indicated you're going to make your decision based on the PTT. And again, how would you choose? If the PTT is just barely elevated, is that going to be a contraindication?
The problem is with the APTT, it's not quantitative, it's semi-quantitative. And if it's slightly prolonged, I think I would still go on with TPA. If it's clearly prolonged, this would constitute a contraindication for the bigatran.
Would it help to know when the patient took their last dose?
Yes, because if the kidney function is normal and the last intake was about 3 half-lives ago, which would be somewhere between 28 and 36 hours, I think it's safe to use thrombolysis. Now, if the patient has compromised kidney function, which obviously he doesn't have, but in this case we would need a longer time window.
Okay. And then for one of the 10A inhibitors, your practice would be to try to get that urgent 10A lab test, or that's not available at all places. What do you do if you don't have the test?
Yeah, then you cannot do thrombolysis. I think this is why taking the history is so important, and it's so important that relatives come along with the patient. So sometimes, let's say the wife knows which drugs the patient takes, and if the taking the history clearly indicates it is a 10A inhibitor, but the last intake was more than 36 hours ago, it's okay to do thrombolysis and not wait for the coagulation tests.
Okay. So let's assume that you do get the history that it is a 10A inhibitor, then 36 hours is your line in the sand. Is that for all the 10A inhibitors? You're basing that on trying to get 3 half-lives?
Yes, because the half-lives are almost identical across all of the novel anticoagulants.
Okay. So for example, say the patient was taking edoxaban and the last dose was 8 hours ago and he's got an M1 occlusion. Are you going to give the TPA? Are you going to think about going to the cath lab? What would your therapeutic options be?
Yeah, well, in this case, TPA, systemic thrombolysis, would be contraindicated, but thrombectomy is not contraindicated. From all what we know until now, there is no increased risk of intracerebral bleeds with thrombectomy in anticoagulated patients. Now, the data we have at present are mostly for warfarin-treated patients, but the few cases we have with novel anticoagulants also indicate that there is no increased risk of intracerebral hemorrhage with thrombectomy.
Okay, great. So the bottom line is you try to get the TPA in if it's feasible, and then if they're not responding, or this is an M1 occlusion patient, how do you decide when to pull the trigger on going to the cath lab?
Immediately.
Immediately.
We, as standard of care, we do CT and CT angiography. If we see an M1 occlusion, the patient goes directly into the angio suite. And before that, we decide, do we kind of bridge with TPA, or do we do, like in this case, if there is a contraindication, directly proceed with thrombectomy?
Terrific. Yeah, time is obviously critical, and the M1 occlusions don't dissolve all that frequently with TPA, so a good chance we're going to need more than just TPA for that patient. Okay, so let me give you a little variation on the scenario. Suppose we find out that this patient really wasn't compliant, wasn't taking the anticoagulant, and TPA is given to the patient. Patient has a reasonable recovery from the stroke. 3 days later, they have a mild aphasia. There's very mild hemiparesis, but they're doing pretty well. We're now 3 days out. They've been off their anticoagulant. When do you start it up again?
Well, here the issue is that we do not have scientific data to guide us. The background is, and in all of the randomized trials where the non-vitamin K oral antagonists were compared with warfarin, people who had a stroke in the last 4 weeks were excluded. So all I can give you is expert opinion.
Okay.
And the expert opinion is the so-called 1-3-6-12-day rule, or Diener's law in the ERA guideline. And it says if someone had a TIA, you would start on day 1. If someone had a mild stroke like our patient, you would start at day 3, so this would be the time to start. If someone had a moderate stroke, you would wait for about 6 days, and in someone with a severe stroke for about 2 weeks. The reason is that on one side we have a risk of recurrent ischemic stroke, on the other side we have the bleeding risk associated with anticoagulation. And with this kind of rule, we try to balance benefit and risk.
Mm-hmm. So for this rule, do we consider how large the stroke looks on the imaging, or we're focusing on what the patient looks like?
It's both. So we first look at the severity of stroke based on the NIHSS score, but we also look at the size of the infarct. You can have a severe stroke with a very small lesion, and in this case you could start anticoagulation, let's say, after 6 days. But you could also have a moderate stroke and a huge infarct on imaging, then you would have to wait. There are other criteria, like, for example, if someone has uncontrolled hypertension, you would have to delay the initiation of anticoagulation until the hypertension is well treated.
Okay, well, that makes sense. So for this patient, they're out 3 days, fairly mild clinical syndrome. They've got an M2 branch occlusion that you can see on the CT scan. Are you ready to start the anticoagulants?
Yes, in this case I would start on day 3.
Okay, do you want to take another picture of the branch just to see that there's not a hematoma there? Or?
Well, not if someone had a mild stroke. But if someone had a moderate or severe stroke, I think I would do a repeat scan to see whether there is hemorrhagic transformation, and this means there is blood in the ischemic area. If this is present, in particular in patients who showed a secondary deterioration of the neurological symptoms, I would delay the initiation of anticoagulation for a few more days.
Okay, but some petechial hemorrhage within the ischemic core
is not a contraindication for anticoagulation.
Terrific. Okay, well then the question is, which agent? What are you going to give this patient? Are you going to start warfarin? Is there going to be a bridge with heparin therapy? Is it going to be one of the newer agents?
Yeah, the choice, I think, is straightforward, because in secondary stroke prevention, what the meta-analysis across all of the 4 trials clearly showed, there is a 15% risk reduction in a further stroke with novel anticoagulants compared to warfarin, and there is a 60% reduction in the risk of intracranial bleed. So I think in this case, warfarin is not an option. It has to be a novel anticoagulant.
Mm-hmm. Right, so you just start the novel anticoagulant. You don't need to worry about any type of bridging therapy.
Yes, and I would even say bridging. Well, If you consider aspirin as bridging, it's okay. So you would start immediately after the stroke with aspirin. And the huge advantage in this case, if you switch to a novel anticoagulant, you just stop the aspirin on the day when you start the novel anticoagulant. This is tricky in someone who would go on warfarin, because you know it takes 3, 5, 7 days until the INR is above 2, and only then you can stop the aspirin. So it's much more complicated with warfarin.
Okay. So with the novel agent, we have a question about reversal, right? That's one of the concerns some people have with a novel agent. How do we turn it off if the patient starts bleeding after you've started the agent? So what are the options here in terms of reversal agents for these new anticoagulants?
I think this is a major breakthrough, because now we have 2 reversal agents. One is idarucizumab, which is a monoclonal antibody which neutralizes the bigatran, and it normalizes the coagulation system within 5 to 10 minutes. And the other one is adexanet, which works on all of the 10A inhibitors, and in a similar way, it basically normalizes the coagulation system within 10 minutes. It has to be given as a bolus and then as a continuous infusion. Idarucizumab is already available. So in people who are anticoagulated with the bigatran and have an acute stroke, I would be happy to give the antidote and then 15 minutes later start with TPA. We hope that adexanet will be available sometime during this year, and then I would simply do the same in people who are on a 10A inhibitor.
Yeah, well, that's really interesting. So obviously, this takes away some of the anxiety physicians may have about what to do in a bleeding situation. No bleeding situation could be more frightening than a brain hemorrhage. So you've got
Right.
something to give in the ER in a brain hemorrhage. But what you're bringing up is really interesting. So one of the patient we talked about earlier, if this was a patient who had taken their 10A inhibitor within 8 hours, you would go ahead, give the antidote, and then go right ahead with TPA?
Yes. And from all what we know, there is no interaction between the antidotes and TPA. So there is no concern that there would be an increased bleeding risk or there would be pro-thrombotic activity of the antidote. So I think this would be, but we need to collect prospectively information now about this concept.
Okay, terrific. So let's just take the scenario that we've restarted the anticoagulant therapy. You've chosen one of the novel agents. The patient's doing well. And then, unfortunately, a few days later, there's a sudden deterioration. Patient develops a headache, aphasia, hemiplegia, do an urgent CT scan, and there's a brain hemorrhage. What's your plan now?
Well, first of all, this is a very unlikely scenario, because the risk of bleeding into the brain with the novel anticoagulants is much lower than with warfarin. But now it happened. So I think if you have the antidote available, you would give the antidote to prevent the growth of the bleed. It has no impact on the initial size of the bleeding until adexanet will be available to antagonize the 10A inhibitors. What you could do at the moment is to use APCC, so activated prothrombin complex, perhaps even in combination with fresh frozen plasma, because for warfarin-induced bleeds, at least we know that the combination of these two things is obviously more effective than each approach alone. The problem with fresh frozen plasma is, number one, it takes time because you have to defroze it to thaw it, and the other problem is the volume you give. So people who have heart failure will have a problem with fresh frozen plasma. But what I want to point out here is, for warfarin, we have no specific antidote. All we can do is give APCC.
Okay. So this would hold, similarly, a patient comes into ER with an acute brain hemorrhage, and if you think that they're on one of the novel anticoagulants, again, what would your recipe be for that patient?
Well, again, like in the case of ischemic stroke, I would take the APTT. If I assume the patient is on the bigatran, and then would use the antidote for the bigatran. If I assume the patient is not on the bigatran, I think I would start with the antidote and not wait until I get the results from the coagulation test, because I would lose too much time.
And in a hospital where the antidote is not available?
Well, at present, at least the idarucizumab is available in all emergency rooms in Europe and in the United States, and I assume the same will happen when adexanet is approved.
Okay, terrific. All right, well, I want to thank you, Dr. Diener. It was very insightful commentary on some interesting clinical scenarios, and I also want to thank the viewing audience for listening to this program. Please visit our page for additional programs in this series, and you can click on the Earn CME credit link to take the CME post-test and evaluation. Thank you.